You just got your cervical MRI results. The radiologist report is sitting in front of you, and it says things like disc osteophyte complex, moderate foraminal stenosis, spondylosis, and your doctor had maybe 4 minutes to explain it. In this video, I'm going to walk you through exactly what I look for when I sit down with a cervical MRI. The same evaluation I do for every patient who walks into my office. By the end, you'll understand the 3 most important things surgeons look for: what cervical disc herniations actually mean, the difference between radiculopathy and myelopathy, and, critically, why not everything on your MRI report is actually causing your symptoms. If you search for something like how to read a cervical MRI, what does my MRI report mean, you're in exactly the right place. I'm a spine surgeon. I've done this evaluation thousands of times. And the most common thing I hear from patients is, nobody explained this to me. That ends today. I specialize in cervical and lumbar spine surgery. Every week, I review dozens of cervical MRIs. I'm not going to give you a radiology lecture. What I'm going to give you is the surgeon's eye, what matters to your surgeon on these images and what we do about it. Let's start with what a healthy cervical spine looks like on MRI, because you need to know the baseline before any of the pathology makes sense. The cervical spine is the 7 vertebrae in your neck, C1 through 7. Between each vertebrae is a disc. It's like a shock absorber, made of a tougher outer ring called the annulus and a soft gel-like center called the nucleus pulposus. Running through the middle of the entire column is your spinal canal, and inside that canal is your spinal cord. Branching off from the spinal cord at each level are nerve roots. They exit through small tunnels on either side of the vertebrae called the neuroforamina. Those nerves travel down into your arms, and each level controls a different region. When you look at a cervical MRI, the most important view is what we call the sagittal view. This is the side view, sliced right down the middle of your neck. Imagine if you're cut in half and we're looking from the side. On a T2 weighted MRI, which is the most common type that we ordered, fluid shows up bright white. Bone is dark. Healthy discs are bright in the center because they are well hydrated and fluid looks bright. And the spinal cord sits in the middle of the canal with bright fluid surrounding it on all sides. When you see that bright white cushion around the cord, that's a good sign, which means that the spinal cord has plenty of space. The levels that are most commonly problematic in the cervical spine are C4-5, C5-6, and C6-7. These are the workhorses. They carry the most load, so they tend to degenerate faster. A healthy disc on MRI looks bright in the center, good water content, good height. A degenerated disc looks dark and flat. That's called disc desiccation. It's essentially the disc drying out over time. Disc degeneration alone is not a diagnosis. Almost every adult over 40 has some degree of it. What matters is what happens next, and that's where disc herniations come in. A cervical disc herniation is when that inner gel material, the nucleus, pushes through the outer ring of the disc and presses against something it shouldn't. Think of it like a jelly donut. If you squeeze it, the jelly squirts out to one side. In your neck, that jelly can press on a nerve root coming out of your spine, or in severe cases, on the spinal cord itself. On MRI, we look at disc herniations from 2 angles. The sagittal view again, which is from the side, which gives us the big picture. And the axial view, think of it like looking down through the neck from above. On the axial view, we can see exactly where the disc material is going. Is it central, pressing on the spinal cord? Is it paracentral, pressing toward one side of the cord? Or is it foraminal, squeezing directly into the tunnel where the nerve exits? The location of the herniation is everything. Central herniations that press on the cord are a completely different problem than foraminal herniations that press on a nerve root. Same disc, but completely different diagnosis and completely different treatments. We also grade disc herniations by how much material has come out. A disc bulge is mild. The disc is spreading out evenly like a tire that's a bit low on air. A protrusion is when material actually starts pushing out in a focal area. A disc extrusion is when the material has burst through. A sequestered fragment is when a piece has broken off entirely and is sitting free in the spinal canal. That grading matters because it changes urgency. A small protrusion in someone with mild arm pain is watched very different than a large extrusion with spinal cord compression. Here's something most patients don't know. The most common symptom of a cervical disc herniation isn't actually neck pain, it's arm pain, numbness, tingling, sometimes even weakness. And that's because most disc herniations compress a nerve root, not the cord itself. When a nerve root gets compressed in your neck, it fires pain and symptoms down the path of that nerve, into your shoulder, arm, hands, and fingers. That's what we call cervical radiculopathy. This is one of the most useful things I can teach you, because if you have cervical radiculopathy, your symptoms often tell us exactly which nerve is involved. C5 nerve root, pain and weakness from the shoulder down into the upper outer arm, and difficulty raising your arm to the side. C6 nerve root, pain shooting down all the way into the thumb and index, weakness with wrist extension, and this is the most common level that we see for radiculopathy. C7 nerve root, symptoms go down into the middle finger. You may experience tricep weakness, trouble pushing down or doing a push-up, and this is the second most common. C8 nerve root, numbness into the ring and small fingers, hand weakness or difficulty with grip. Now, when I'm looking at your MRI, I'm doing two things simultaneously. I'm looking at the images and I'm looking at you. I'm asking, where are your symptoms? Which fingers are numb? Which movements are weak? The diagnosis of radiculopathy is clinical first, imaging second. Your MRI might show a disc herniation at C5-6, but if your symptoms are in a C7 distribution, something isn't adding up, and I have to figure out why. Now, sometimes nerves and their distribution is not exactly textbook, so sometimes you may experience symptoms in a different distribution from a nerve where we would not expect it. This is why I always tell my patients, your MRI result and your symptoms have to match. If they don't, we have to be very careful. Finding something on an MRI doesn't automatically mean it's causing you a problem. Now I need to talk about something different, something more serious. Everything I've described so far, disc herniations, nerve root compression, radiculopathy, those are painful conditions, but most of the time they're non-emergencies. Most of the time we have time to try conservative treatment first. Myelopathy is different. Cervical myelopathy means the spinal cord itself is being compressed, not a nerve root, the actual spinal cord. The spinal cord is not like a nerve root. Nerve roots can tolerate pressure for a long time and often recover fully when the pressure is relieved. The spinal cord is far less forgiving. Prolonged compression of the cord causes permanent changes to the nerve fibers inside it, and those changes can become irreversible, even after surgery. This is a fundamental difference in urgency. Radiculopathy gives us time to be conservative. Significant myelopathy, especially with signs of cord damage, is a condition where surgery is often the right answer right away. On the MRI, myelopathy shows up in a couple of ways. First, we can see the cord being physically compressed, or the bright fluid cushion around the cord disappears at the level of compression, and the cord looks pinched. The second, more serious finding is something called T2 signal changes within the cord. On the MRI, you'll see a bright spot inside of the cord itself, right at the level of compression. That bright signal means there has been damage to the cord at the cellular level. It doesn't always mean permanent damage, but it does mean the cord has been under enough stress that we need to take it seriously. Symptoms of myelopathy are different from radiculopathy. Instead of pain down the arm, patients tend to describe a kind of global dysfunction. Their hands feel clumsy, dropping things, trouble buttoning shirts, balance problems, a feeling of heaviness or stiffness in their legs, sometimes a shocking sensation down the spine when you bend your neck forward. That's called Lee-Hermite sign. If any of those symptoms sound familiar and you haven't seen a spine surgeon yet, that's the next step. Not a physical therapist, a spine surgeon who can look at your MRI with your symptoms together and make the right call. All right, here's the part I think will actually make you feel better. One of the most important things I've learned doing this for years is this. The severity of your symptoms and the severity of your MRI findings are not the same thing. Studies on asymptomatic adults, meaning people with zero neck pain, no arm symptoms, show that a huge percentage of these patients have disc herniations, disc degeneration, foraminal stenosis, even spinal canal stenosis on their MRI, meaning their spine looks abnormal on imaging, but they feel completely fine. On the flip side, I've had patients come in with debilitating arm pain, barely functional, and their MRI shows only a mild to moderate herniation. Their suffering is real, their MRI just doesn't look dramatic. This means two things. First, a bad-looking MRI is not a surgical indication. Second, a mild-looking MRI doesn't mean your pain isn't real or isn't significant. What we're actually doing when we evaluate you is triangulating. We take the MRI findings, we take your specific symptoms, their location, character, onset, what makes it better or worse, and we take the physical examination, reflexes, strength, sensation, and some special tests. When all of those three converge on the same level, the same nerve, the same finding, that's when I have confidence that what we're seeing on the MRI is actually what's causing your problem. That convergence is what drives treatment decisions, not the MRI alone. So what do you actually do with this information? Whether you've just gotten your MRI results or you've been sitting on them for weeks, here are three questions that matter most when you see your doctor. Number one, does the MRI finding match my symptoms? Ask your doctor specifically whether the level they're seeing on imaging corresponds to the arm, shoulder, or hand symptoms you've been describing. If the answer is unclear, it's important to understand. Number two, is there any type of cord compression? That is the myelopathy question. Even if you don't have the classic symptoms, ask your provider to specifically comment on cord signal, canal diameter, and the most compressed level. Number three, what's the natural history if I do nothing right now? Most cervical disc herniations with radiculopathy or foraminal stenosis with radiculopathy improve significantly with conservative care over 3 to 6 months. So ask whether your situation falls into that category or whether there's a reason to be more aggressive earlier. Here's the summary. A cervical MRI is a map. The three big things we evaluate are disc herniations and their location, nerve root compression causing radiculopathy, and spinal cord compression causing myelopathy. Of those three, myelopathy is the one that demands the most urgent attention. Radiculopathy, arm pain and numbness from a pinched nerve, is the most common presentation. And the level of the nerve, as I showed you, tell us usually exactly where on your spine the problem is. But the MRI is just one piece of the puzzle. Your symptoms and your exam are just as important. Never let anyone tell you that your MRI makes the decision. The MRI informs the decision, so that's a big difference. If you have a lumbar MRI, lower back or leg symptoms, I've done a full breakdown of that too. The link is right below. And if sciatica is your issue, that video is going to explain exactly what's happening physiologically and what your options are. I'm Omar Ramos. I'm a spine surgeon at Twin City Spine Center in Minneapolis. This channel exists because the more you understand your spine, the better decisions you'll make about it. Subscribe if this was useful, and I'll see you on the next one.